Jaundice in the neonates may be visible when the serum bilirubin level exceeds 100 micromole per liter. Neonatal jaundice is important because of the consequences of hyperbilirubinemia on the brain of the newborn, and this condition is called kernicterus, as bilirubin encephalopathy, and may cause death. Infants who survive may be handicapped with cerebral palsy and associated deafness, mental retardation, and motor incoordination. Approximately 80% of newborns will be jaundiced in the first week of life, and most of this is physiological. So this occurs on day 3 and lasts up to 10 days. And this jaundice is mild and the baby remains healthy. Jaundice in the neonates is likely to be pathological if it presents within the first day of life, or conjugated bilirubin is more than 40 micromole per liter as a direct bilirubin, or the total bilirubin is more than 170 micromole per liter in preterm, or more than 260 micromole per liter in the term infant, or the neonate is significantly jaundiced beyond 14 days, or has jaundice with fever. So exchange transfusion is a definitive treatment for hyperbilirubinemia that has reached a level where kernicterus may occur. The causes are physiological hemolysis, resource ABO incompatibility, GSPD deficiency, also blood extravasation like cephal hematoma, subgaleal hematoma, sepsis, congenital infections, liver disease, metabolic disorders like galactosemia, hypothyroidism, and also enhanced extra hepatic circulation like GIT obstruction, inadequate feeding, also congenital defects of bilirubin metabolism, and breast milk related jaundice. Symptoms are yellow eyes, yellow skin, hands and feet, and pale stools. As for this, biliary atresia is likely. So the signs that are usually elicited are jaundice, yellow pigment in skin, yellow palms, with or without yellow soles of feet, and pale stools where biliary atresia is likely. And the investigations are total and direct serum bilirubin concentration. Other investigations dependent on the age at presentation, and then also the suspected cause. So for early onset, as within the first 24 hours of birth, blood group and resource group of both infant and mother, direct Combs test, indirect Combs test, also FBC, GSPD, and blood film for red cell anomalies, malaria parasites, also cultures of blood, urine, and spinal fluid may be indicated by the history, physical examination, or even the initial lab findings. For prolonged jaundice after 14 days, do LFTs, the liver function test, thyroid function test, urine for reducing substances, urine REN, and culture sensitivity, as you do a touch screen, or congenital infections, and Hep B, and also abdominal ultrasound scan exclude as to exclude biliary atresia. The main treatment objectives are to prevent kernicterus as bilirubin encephalopathy and to detect and treat underlying cause. Non-pharmacological treatments, phototherapy, and also exchange blood transfusion. So for phototherapy, it is started if jaundice is visible on day 1, and jaundice involves if the jaundice involves the palms and soles of feet, and jaundice in prematurity, and after day 2 Um, and the measured level of unconjugated bilirubin is more than 170 micromole per liter in preterm, or more than 260 micromole per liter in term neonates. We start phototherapy. So a phototherapy unit with blue fluorescent tube lights is preferred. If unavailable, white fluorescent tubes may be used. The baby's eyes must be covered but should be examined daily for any infection. Continue breastfeeding during this time and ensure adequate fluid intake. Prevent hypothermia or hyperthermia, and phototherapy should be continued till unconjugated bilirubin levels remain below phototherapy levels for at least 24 hours. For extended therapy, use warm blood, 37 degrees Celsius, and cross-matched against maternal and infant serum as 160 milliliters per kilogram over 2 to 3 hours. Monitor the heart rate, respiratory rate, bilirubin and blood glucose levels during the procedure. Further exchanges may be needed if the bilirubin level continues to rise, and stop the exchange transfusion if the heart rate fluctuates by more than 20 beats per minute. Lower levels of bilirubin than stated should be considered for intervention by phototherapy or exchange transfusion in the following cases: so sick or low birth weight babies, or following asphyxia and prolonged hypoxemia, acidosis, and sepsis. Since there is no exact test to determine the risk of kernicterus, and hence the level at which exchange transfusion is necessary, the following rule of thumb has provided useful as a guide, as when serum bilirubin is more than 340 micromole per liter in term infants, more than 2 kilograms. Also in newborns weighing less than 2 kilograms, serum bilirubin exceeding the following would require exchange transfusion. Okay, so less than 1 kilogram and having 170 micromole per liter, and 1 to 2 kilograms 250 micromole per liter, and called HB, hemoglobin, less than 12 grams per deciliter, or called bilirubin more than greater than 80 micromole per liter. And also rapid progression of anemia in presence of resolving jaundice, and hydrops fetalis, it requires immediate exchange transfusion with packed cells. Okay, so for pharmacological treatment, you treat underlying sepsis. Referral criteria: refer immediately all babies who develop jaundice within 24 hours of life, or who have prolonged jaundice, to a pediatrician, and refer all patients requiring exchange transfusion to an appropriate facility.